I got South America, North America, Africa, Southeast Asia, MENA region, and today we have Europe. And today we have the IWGDF meeting. Yeah, you can start sharing. You can start. Yeah. So I would like to welcome all of you, all the attendees who are not seen, but they're attending to a virtual platform. And today we have as the first speaker, Professor Nicholas Schapper, who's the chairman of IWGDF and the ISDF. And we have our chair from Europe, Robert Ancini, and our president-elect, Abbas. So Abbas, you can say a few words and then pass on to Roberto.
Thank you very much, Vijay. It's my pleasure and honor and a privilege to be part of this, to have International Working Group presenting and doing this. You are all most welcome. Thank you very much. Roberto.
Thank you. It's a pleasure also for me to stay here with you in this day, a good diabetes day. We talk about awareness and education. Our role in this moment is to improve these words that have a different significance in the different means in a different person. For example, in a healthcare professional, in the patients, in the government, or in the caregiver. So it's so important that DFood International put all together to improve this aspect. And this is very, very beautiful. I thank you to International Working Group Diabetes Food to improve a guideline, because based on the guideline we can go over for diabetes food management. Thank you, and a good Diabetes World Day.
So the first speaker is Professor Nicholas Schapper, who will be talking on general process and methodology update. And the topic for today is shaping the IWGDF 2023 guidelines, creating evidence-based and clinically relevant guidelines on diabetic foot disease. So on to you, Professor Schapper. We're honored to have you.
Thank you very much, Vijay. It's an honor to be able to be here and that you give us the opportunity to present the work we are doing and have been doing on the guidelines, which for many years now also have been a collaboration with DFood International. And we appreciate that collaboration very much, because you helped us in implementing the guidelines and reaching our target audience. And quite a few of the DFood board members and other members are actually also closely involved in formulating the guidelines. So I think this is a very fruitful collaboration. And if I speak on behalf of the whole International Working Group Diabetic Food team, we are very honored to be here. And I welcome also the participants, of course, very much. In my country, it's a beautiful day, blue sky, sun is shining. So I hope it's the same with you. And then I'm very much amazed that you're willing to give up your weekend day and to spend some time with us on this topic, which at least for many of us is something which we are, how do you say that in English? We are so motivated to improve the care of our patients. So I'll give you a brief outline about the history of the guidelines. I'm trying to now get the next page. Yeah. Why actually do we need guidelines on the diabetic foot disease? Well, there is a rapid increase in knowledge in many of the fields related to the diabetic foot, be it infection, be it peripheral arterial disease, wound care, prevention, etc., etc. And you can see that here on this slide. In the 80s, last century, we only had 30 publications on the diabetic foot. And in 2020, when I made this slide, that increased dramatically to 1,407. So we are all flooded with a lot of knowledge, with a lot of publications, some of poor quality, but also quite a few of high quality. And we have to integrate that into our daily care. So we as clinicians have been flooded by so many different specialists from so many different fields with their knowledge, with their way they think we should tackle the problem. We have to integrate that in a multidisciplinary guideline on the diabetic foot. And to be enabled to treat the patients successfully, there are conditions for successful management and prevention of a diabetic foot ulcer or other problems related to it. And that's, of course, that you have a team which speaks the same language, which has the same goals, which uses the same way to classify a patient. You know, if I talk about an infection, but the surgeon has a completely different viewpoint what an infection is, then we have a problem, as shown here in this slide. So we have to align all the different members of the team, and for that we produce multidisciplinary guidelines on all the various topics of the diabetic foot. We started in 1996. You can see that here on the left side, with some people are still involved, but now in a much older version, like Jan Appelquist, myself on the left. And of course, it all started with Karel Bakker, who took the initiative and got people like Andrew Boulton and others on board. And here on the right, you see it how we did it in those days, sitting in a dark room, a cellar somewhere in a hotel, and then producing guidelines. We called evidence-based, but nowadays we would say they were expert opinion-based, although I was not very much an expert at those days. And for instance, for 2019, we could only do all that work because we had sponsors of the industry, and we are very grateful for them for doing that, because without these sponsors, it would not have been possible to produce these guidelines, because we are a completely independent organization. And of course, the price for that is that we do need external support, and that has been given without any condition. That's by the various sponsors shown here in 2019. And again, we have a list of new sponsors coming up for the next guideline. And that's what I'm going to talk now. In the next guideline in 2023, we will have practical guidelines, guidelines on prevention, offloading, peripheral arterial disease, infection, wound healing, Charcot, that's a new chapter, classification, and then a chapter on how we did it, the development and the methodology. And all these chapters are based on 11 systematic reviews, and we have a chapter on definitions and criteria. So we speak all the same language, as I mentioned earlier. And these are all the people involved in the guidelines. So we quite a lot of experts. And of these people shown here in this slide, I can't name them all. We have an editorial board. Because of time, I won't mention them too, but many of the editorial boards are here present. We have 7 working groups on these different chapters I just shown. And then we have a lot of external experts, more than 50 all over the world. I'm going to show you that soon. And we have a series of collaborating associations like DFOOD, but also the World for World Vascular Society. We have the American Infectious Disease Association. They're all involved in these working groups and help us formulate our guidelines. And here you see a beautiful slide made by Jaap van Nette, our secretary, showing in color all the different countries that are involved in the guidelines. The red is the working groups, and the yellow color are where also external experts are from. So we do think that we do cover truly a lot of the world. Of course, not the whole world, as you can see, but most of it. How do we do it? Well, I'm not going into that too much detail, but it is important for you to realize, and it's also one of, maybe you could say, the weaknesses of our guideline, is that we have to do it in a completely transparent way, which is reproducible, and which follows current definitions and criteria of how you develop a guideline. You can't just go back to a cellar like we did more than 20 years ago and, get a bunch of experts and pick your literature that you like, and then you write a guideline. No, it is now a very rigorous process, which takes a lot of time. You formulate your clinical question, we call it a PICO, then you formulate your outcomes, the outcomes that are critical, the outcomes that are important and not important. Then you do your systematic review of the complete literature. Then you grade the literature. Then you look at different aspects of the literature shown in the right, the risk of bias, but also the inconsistency of the data, the indirectness of the data, imprecisions, etc. And then this group of experts, and they are a mixed group of clinicians involved in writing systematic reviews, but also clinicians involved in clinical research and daily practice, they together, with the input also of patients, formulate their recommendations, and then these recommendations are sent out for external experts to review, and the original and this various organizations I mentioned earlier. And actually these experts and organizations were also already involved fairly early on in the process in formulating the PICO. So we try to embed it as much as possible in daily practice, although it is a rigorous process, and that also has sometimes limitations. At the end, we formulate recommendations, something like this. You can find that in our 2019 guideline, and something like this will be maybe in the 2023 guideline. And a person with diabetes and a food also use the SINBAD system for communication among health professionals about characteristics of the ulcer. This was 2019, and I do not know what it will be in 2023. But as an example, and then we say strong, because it means that this is something we feel that should be done. Otherwise, we say you consider, and we call it a conditional guideline. And then that means that you should indeed consider it, but there are situations where you should probably not do it. And then the second word, moderate, means the quality of the evidence based on the systematic review and additional arguments. Below the recommendations, you will find a rationale in which we try to explain how we came to this recommendation, its strength, and the assessment of the evidence. Of course, rigorous methodology has a price. Here you see our secretary, at least a theoretical secretary, because then I would have had a picture of Jaap here. But of course, we have secretaries for each working group also, and they do a lot of work together with the chair, of course. We calculated that in 2019, it was 10 years of full-time work if one person would have done that. And if you translate that into payment costs, it's 2 million euros in kind. So we all work for nothing. We all work, I hope that it's not for nothing as a result, but we do it for free. We work in the night, we work on weekends, on holiday days, and that's a huge undertaking. So thank you very much for your patience and for this giving me the opportunity for this brief introduction. And I'm looking forward to your questions at the end of my talk. Thank you.
So the tech team, is there any questions? Or can you send it in the chat box? Okay. So we will next move on to Dr. Matilde Monteiro. Dr. Roberto or Yap, would you like to take over? She'll be talking to us on classification.
Thank you very much. I'm very sorry because perhaps you need to put the volume a little bit higher, but I'm doing my best so that you can hear me. So I will be discussing with you about the topic of the questions about the guidelines on classification. And the subtitle of this is, can this guideline be classified? Because it is really interesting, because having this presentation right after the Nicholas Schaper presentation, because the problem with ours and about classification is that we will have a slightly different methodology when you look and compare with the other guidelines. So this is a really specific and a really interesting group to be working with, because we have been learning a lot throughout the process on how to do and how to best answer to this question. So you can see here on this slide also the current group. And what you can see is that from 2019, we have included 2 additional persons to our group in comparison to the previous round. And our intention is, as Nicholas has said, to increase the group and also the representativity of people from other countries that were not in our group in the beginning. So the first question is, why do we think that to systematically classify ulcers is so important? Basically because we know there is so much heterogeneity in the beginning, because there are different causes for an ulcer, and we can have different predisposition or factors related to delayed healing. We can have different outcomes that we can consider as really important and mainly focus on healing and amputation. But we know that in clinical practice, we will look to much more besides these outcomes. And also what we would like to know is, when facing a specific ulcer in front of us, what should we do? What should be the best management strategies, and mainly focusing on offloading and infection and revascularization. So we truly believe that we need to use specific classifications for specific clinical scenarios. One of them is, like the example that was given in the previous talk, how to communicate among health professionals about the characteristics of a diabetic foot ulcer. So how can I say that a person should pass from a primary care to a tertiary care and to have an adequate referral if I don't know what I should communicate and what should I tell to the other health professional? This is the case that I have, this is an urgent case. In which variables should we focus on? The other part is more related to the patient itself. So how can I tell a patient what is his prognostic, what is his expected prognosis and the outcome that we think that will come from this specific ulcer? The other, as I said before, is to guide management, mainly focus on the infection treatment, but also on the benefit of revascularization of the index limb. And also, as much importance as in the other scenarios is also the question about audit and the comparison between institutions. Are we being effective in our organization of healthcare? Are we comparable between countries? Is just the differences on the characteristics of the ulcer the reason why we don't have the same results? Or should we look into our institutions and change the management and change also the flow of our patients? So one of the major differences was that our group was created in 2019. And so on this round, we made a critical review instead of a systematic review. And this led to a major change in what we thought that we knew about this topic. So in 2019, we had identified 19 different systems that had been validated on diabetic foot. This was around the inclusion of about 50 articles. But now we identified 28 systems that were addressed in more or less 150 articles. So we need to extract and do the risk of bias of 150 articles and to understand the evidence about and around these 28 different systems. The other question was that we also did a more light approach about the grade, and now we had the full scope of it. So what does that mean? First of all, to have a really good selection of what we consider as critically important outcomes. And this passed for external reviewers, but also by patient representatives to understand to which outcome should we consider as the most relevant. And you can see in here that besides the most directly linked clinical outcomes like amputation and healing, we also looked at the impact of classifying adequately on hospitalization, survival, and also health-related quality of life. Also post-baseline ulcer clinical outcomes like being free of another ulcer and being free of an amputation. But another question and aspect that is really, really relevant around this topic is about the usability and also the use of resources to be able to apply a specific classification or system. So first of all, we need to understand that we will have two completely different tools. One of them is the classic classification, so a descriptive tool that was created to divide patients into groups. But we need to understand that this will not necessarily be related to the risk of adverse outcome. It's just a way of splitting people in more homogeneous groups, but not specifically with an increase on the likelihood of having a specific outcome. The other nature of systems that we have are the scoring systems, and this will attribute a scale, and each factor and the contribution of each will be amalgamated in combination with each other, and they will produce a numerical, usually a numerical score that with the increase of that score, we will see a different likelihood and a higher likelihood of risk of adverse outcomes. So the question is that we will not be looking for interventions. Our group will only look at prognostic studies. And so what we will be focused is on predicting the future course of events following the onset, on this case, of that ulcer of reference. What we are looking is to be able or to estimate the probability of, for example, having an amputation or requiring hospitalization, or to discriminate, and in this case, focusing more on accuracy measures between those who will develop or not that risk event. So for that, what we were looking for was for the risk of bias for the quality in prognostic studies. But another aspect that we had to look into was if there is any measurements about reliability. So if when we use and apply a classification, we will reach the same results in different situations or in different health professionals using this. So here again, we had to use different methodologies, and we had to do and to apply two different tools to assess the risk of bias. Now, if you look at the tripod statement, and this is the one that we should use when we are talking about multivariable models, and one of the things that we can see is that we will have a really gray area between diagnostic and prognostic studies. And the question was that if we look at the grade system and the summary of judgments just for prognostic, we would be really limited to the items that we should be looking at. And so one of the things is we need to look at classifications in a way that if we can accurately stratify people by their risk of developing those critical clinical outcomes, we intend to change clinical management and hopefully change the clinical course. So we need to look at the classifications in a way that if we stratify people, we can do better, and so we can prevent outcomes. And so we also need not just to look at the accuracy, but also to the effect of that test on clinical management, if this will really relate and have an impact on our clinical care. And so the other thing that we really need to look into is about at what costs and to whom. So do we consider that the resources required are reasonable? Do we think there is any type of cost effectiveness about using this strategy to make our decisions? Do we believe that this will have an impact on health equity and hopefully improving it? And the other question is on health professionals. Do we think they consider this as feasible and acceptable? So as we can see in the classification groups, besides having 28 different ones, we need to look at the evidence that exists mainly for accuracy, but we need to think on much more if we want to decide in which classifications should be used for 5 different clinical scenarios. So we will have a really rich discussion in our guidelines. So one of the things that we keep the same conclusion is that we believe that there will never be a single classification system that could be used for all the scenarios. It should be the only one used. And so we will still have recommendations for different ones. The problem is that the vast majority of our classifications had 1 or less externally validating studies and no reliability assessment. So the available evidence is really, really low. We had no system with moderate or high certainty of evidence. So those subjective items had a really high weight on our decisions. And so we thought that only 6 out of those 28 were considered as potentially useful for any of the clinical scenarios and for current clinical use. And so the main message is, yeah, we're still working on the recommendations. We believe that changes will happen between our previous round and this one. But one thing we know for sure, please don't do another one. Look at what already exists and please give us more evidence so that we can make better recommendations on the previous round. So we will depend on your work. So thank you very much for your attention. And if you have any questions, please feel free to do it.
Thank you, Dr. Matilde, for all the hard work that you have done for the 2023 guidelines and for taking part today, in spite of the fact that your throat is not all that okay. So, Abbas?
Yeah.
Want to introduce?
Yeah, the next speaker is Fran Gem, Professor Fran Gem, is a diabetologist from consultant diabetologist at the University Hospital of Derby. And she's one of the part of the International Working Group consensus. And she's representing Wound Healing Group. So Fran, today's topic is wound healing. The floor is yours. Thank you.
Thank you very much. Now, hopefully I'll be able to share my slides and share the correct screen. So forgive me while I just make sure I've got the right set of slides up. Is that sharing the full presentation?
Yeah, it's coming.
Thank you. Okay, so we're talking about wound healing, and a lot of the methodology have been covered, but I make no apology for taking you through some of the specific items of wound healing again. So this is the wound healing group from this year. Sorry, I just flicked over too quickly. You'll see some very famous names there. And as Matilde said, we have expanded our groups this year to ensure that we cover lots of different specialties, but also many regions of the world. And you'll see our DFOT president there, who's been enormously helpful to us in ensuring that we don't have a Western world-centric view of our wound healing guidelines, but also we've got some very well-known podiatric surgeons in the USA. So our discussions are extremely interesting. Now, these were the 2019 guidelines. We did a systematic review in 2019, as well as the guidelines. And if you haven't looked at those, They're about to be updated. At the time, we made 13 recommendations, and I just want to take you through what we're doing differently this time, because the process has been much more rigorous in order to be much more transparent about the recommendations that we've made. Now, Nicholas has already shown you this slide, but we spent a lot of time as a group deciding on the questions we want to ask, particularly around the outcomes. So in wound healing, which are the outcomes that are particularly important to physicians and also to patients? So we had some external reviews from our patients and from around the world, and many of DFUT international representatives were very helpful in ensuring that we had the right outcomes, because we don't have the right outcomes, we can't ask the right questions and we can't make the right recommendations. So that was a really important stage. We spent a lot of time on that, making sure we were asking the right questions, so that when we go to the literature, we're looking at the right studies to answer these particular questions. And when we go to the literature, we pull down all the papers that we think might answer that question, and we do what we call a risk of bias, which is really just a quality assessment, so that in intervention studies, what we're saying here is there any other reason why the outcome might be positive or negative other than the intervention? As in, is there bias? Did one group have bigger ulcers than the other? Did one group have more vascular disease than the other? So this is what we mean by risk of bias. So we look at all of these different items, and it's hugely time consuming, as those of you in the working groups will know. And then and only then, having looked at, asked the right question, done the literature search, do we then move on to looking at making recommendations, which always start with the quality of the evidence on which we're working. Now, in 2019, we looked at controlled studies as well as randomized control studies and case control studies, time series, and we included papers in any language, but obviously they had to include people with diabetes and an ulcer on the foot, so we weren't looking at prevention. And our outcomes at the time were healing, change in ulcer area, and amputation. And in 2019, this was an update of previous systematic reviews, so we didn't go back and review the literature. We assumed that those that had done the literature reviews had done it properly, but obviously times have moved on since 2004, and what we would think was good healing or good usual care probably isn't the case. So what we've changed this time is we've only looked at randomized controlled trials, largely because every other review we were saying, well, yeah, there's something there, but it's not very good quality, so we're going to ignore it. Well, that's just time consuming. So on this occasion, we've taken randomized controlled trials only, as that's the best quality literature. Obviously, we're still taking papers in any language and people with diabetes and an ulcer on the foot, but with input from our colleagues and our patients, we have extended the outcomes that we're looking at. And in particular, we're looking at resource use, quality of life and maintenance of function. And these are new outcomes that we're looking at. I have to say there isn't much literature on these, but nevertheless, these were important to patients and their carers. So this on the left-hand side shows you the number of titles that we'd identified in these updates as time went on. That's the quantity of the data we were looking at in 2019. The quality was not quite so good. And in fact, when you think this was the world literature since publications began and PubMed was available in any language, in 2019 we only had 284 control studies, with only 172 of those being randomized. So everything we do in terms of wound healing is actually based on a very low number of randomized controlled trials, and actually the quality of that is very poor. So our entire world literature in 2019 consisted of just 44 double-blind trials, and even some of those were still at high risk of bias. We thought we would perhaps get a slight increase in the number of studies we were looking at, And we've screened now over 11,000 titles, and we've pulled over 600 papers full review. These are randomized controlled trials. We were only looking at randomized controlled trials. We think we're going to include around 450 studies. And what we're doing is we're starting again with our evaluations. We're also looking at slightly different categorization of studies. We've re-looked at the way we group studies. So previously we had 11 different categories with subcategories within that. And so we've rationalized that a little bit. We now have 10 different categories, but again, there are subcategories within those. So we've just rationalized things a little bit to make things easier to read in the guidelines. So when we've got all of our papers and we've looked at the subcategories and people have groaned at the amount of work, we then do our risk of bias assessments, and we're using 2 different scales, the Cochrane-Sign risk of bias assessment, which is a standard one for all controlled trials, and also the 21-point checklist, which has some specific questions for diabetic foot disease. And all of our papers have to go through this assessment, and they all get a score. And as I say, then and only then, when we've put all of that together in our systematic review and evidence tables, do we then move to the interesting bit, and that is to look at the recommendations. I've just blown this up because, as I say, we start with the quality of the evidence and then looking at whether any of the interventions could potentially cause harm. You know, there are certainly some harms for some intravenous interventions potentially, and do those 2 things outweigh each other? The values and preferences, well, that's covered. We've looked at the outcomes. We know that that's covered off by our expert opinion, our patient groups. But in particular, we're really spending a lot of time talking about feasibility, equity, and acceptability. And this is where our DFOT International colleagues have been exceptional in their advice, because what we think is feasible and acceptable is not necessarily what patients across the world will think is feasible and acceptable. And obviously, interventions that require have a cost, perhaps repeated testing or expensive interventions, may not be equitable in all healthcare settings. And we also look at the total resource use. So that's a really important step, and we're spending a lot of time on that now, but it all starts with the evidence. So say in 2019, we had 13 recommendations. We're not quite sure how many recommendations we're going to come up with in 2023. They're going to be subgrouped, but quite possibly a lot more. Well, I know more than 13. What we do say is that anything that you put on the top of the ulcer has to be done in addition to best usual care. And that's something we're looking at throughout. If a study's been done, have the patients had best usual care before we put anything expensive on? And I always labour this intensely. Unless you've got the good foundations of good wound care, it doesn't really matter what you put on the top. It's just too expensive and won't make any difference. So all of our studies, we're looking to see whether this was in addition to best usual care. So I've shown you this slide before because I think you now realise the amount of work that these people are doing, and they're all very smiley and happy on that picture because they think they're going to have a really good fun time with us. We are now on our 21st meeting, plus all the additional work in between. So we're very grateful for the amount of work they're putting in. This is the reality. This is a Zoom meeting late at night for some people in Australia, those that are falling asleep, and the sort of shell-shocked looks on some of their faces. This is the reality. It's not, it is a huge amount of work. So thank you all very much for your attention.
Thank you, Fran. I would like to next introduce, there's some questions coming up. I'll ask the tech team to post it in the chat box. Before that, we'll go on to the next talk by Dr. Jaap van Netten on prevention. Dr. Van Jaap Netten is the main coordinator of the editorial board, and he's working at the University of Amsterdam and in the Department of Rehabilitation. And he has been the sort of the brain behind the editorial board. So yeah, welcome to you and thank you for organizing this meeting with DFood International. On to your talk.
Thanks so much, Vijay, and thanks again for this very kind invitation and for organizing this great event, and not only one event, but organizing multiple events during this week. My slides should be visible for all of you, unless, and if they're not, then Vijay, please interrupt me.
Yeah, it's visible.
Great. So this talk is about the prevention guideline. But as with the previous speakers, I'm not going to tell what's going to be in the prevention guideline because we're not there yet. We still have a lot of work to do, although we've covered quite a lot of ground. Here you see the names of the people who are with us working on this prevention guideline. In 2019, and actually also in previous years, what we showed, what we put in the guideline is the 5 key elements of prevention, which is identifying the at-risk food, regularly inspecting and examining the at-risk food, educating patient, family, and healthcare providers, ensuring routine wearing of appropriate footwear, and treating risk factors for ulcerations. Well, it's not surprising, but it's unlikely that these 5 key elements are going to change, which is why I'm happy to put them on right now. But for this talk today and for the next 10 minutes, I want to talk on the 2 specific cornerstones, which is the regular inspection and the ensuring routine wearing of appropriate footwear, or phrased slightly different, ensuring low pressure. Because in those 2 areas, we've seen over the past few years and sometimes even decades, some new technologies and some exciting technologies in ulcer prevention. And I think technologies is a really great tool in ulcer prevention because it helps us to bring in industry. And while we're not envious at all of Frank Game and the wound healing group having to go through 400 RCTs, on the other hand, we would really like to have 400 RCTs in the field of ulcer prevention because we've seen around 8 to 10 published over the past 4 years, which means there's only 2 or 3 RCTs on ulcer prevention on a yearly basis. So everything that we do in preventing these ulcers is based on very limited evidence, and we need much more science and we need much more studies to properly know what we're doing in ulcer prevention. And I think technologies are an exciting topic and may be able to help us. And if we're talking about regular inspection, the key technology here is, can we improve this with temperature monitoring? Can we improve self-examination and self-management? And on the 4th cornerstone, pressure offloading, the question obviously is, can we improve pressure offloading by continuous pressure monitoring? And in those 2 areas, we've seen new technologies. And what I'll do in this talk is present some of the results of our systematic review. So it's not the guideline yet, but it's what we found in the literature and what helps us to assess how we're going ahead with the guideline writing. So I'll first focus on temperature monitoring. What you see here are multiple technologies that all have the same purpose, which is to measure temperature on the foot, often the plantar surface, but some of them are capable of measuring also on the dorsal surface. And so you see multiple technologies that are all out there and that all can be bought in whatever shop you would like to go to. So all these technologies are out there and available. But if you look at the technologies that are actually tested properly in clinical studies, this is all we have. This is the only one that's been properly tested. And okay, maybe you should give some credits to this technology because it has also been tested in the non-controlled studies. But despite having so much technology available to us, it's hardly tested in real studies. Because what we have are 5 RCTs using a handheld thermometer, 3 of them already old, hence the quotation mark around the new technologies, because this is clearly not a new technology if it's been in this field for almost 2 decades. So the 3 older studies are all from the US, and we have 2 more recent studies from Europe. And I have to disclose that on the most recent study, I'm one of the co-authors. And then on the map that you saw, we have 1 non-controlled study, also pretty recent from the US. And I won't go into detail, but surprisingly, that study did not show any difference between the year that the MET was used in ulcers that occurred versus the following year, where patients had to stop using the MET. But I'll focus on the studies where we have proper evidence from high quality RCTs. And these RCTs show you the temperature monitoring is effective. This is a meta-analysis, and what you do in a meta-analysis is that you summarize the evidence from the various studies, and you look at, and I hope that you can see my mouse going through it, but what you want to look at is this black diagram. And this black diamond tells you, if it's on the left side of the line, that it's helping prevent foot ulcers. We see that the risk of getting a foot ulcer is about half in people who monitor their temperature daily and reduce their activity when they find a hotspot. So it's very effective. And that's obviously good news, because that's what we want. We want to prevent foot ulcers. And in our most recent study done in the Netherlands, we also looked at the costs. And as we expected, if you prevent foot ulcers, you prevent spending a lot of cost, because on average, a foot ulcer costs 10,000 euros, something we again confirmed in our studies. And this is what we also showed. We showed that it's cost effective. In the blue bar, you see the average cost during the 18 months of study of people in the intervention group who were temperature monitoring. And in the red bar, you can see the average costs per patient in the usual care, so not having temperature monitored. And you can see that it's cheaper. So it's cost effective. But then there came a big but in our study, and something that we did not expect in advance, because we expected, if you prevent foot ulcers, that you will also improve quality of life, because a foot ulcer reduces quality of life. But surprisingly, what we found, and on the left-hand side, you see again the cost, but here now focus please on the right-hand side, where you see the quality of life. And again, the blue bar is from the intervention, the red bar is from the control. And this time, the intervention being lower than the control is actually not a good sign, because it means that quality of life is reduced in the people who were monitoring the temperature on a daily basis, even though they were not getting the foot ulcer. And this difference was especially markedly seen in those patients who did not get a foot ulcer. We're currently analyzing that in more detail, but we also published a paper on looking in more detail at the adherence. And what we found is that 43% of the participants stopped measuring, and the primary reason to do so was the physical and the mental burden of having to measure the temperature daily without getting any foot ulcer. Because still, even though many people do get a foot ulcer, the majority of patients do not get a foot ulcer. And having to do something on a daily basis and not getting any outcome, that seems to be causing a reduction in quality of life. And a reason to be cautious with implementing new technologies in patients' life, because these patients already have so much self-management going on and have so much technology around themselves and around their diabetes care. And if you look in our and different studies, we saw that the adherence on average was between 61 and 91%, which is quite high. But that was the adherence to measuring the temperature. But if you find the hotspot, you also have to change your activity. And there we found that the adherence was really low. So those patients who did not stop with the temperature monitoring also not often did not reduce their activity, even though they found a hotspot. So even though it's effective, it's questionable if the effect is really due to the technology or if something else is going on here. So summarizing all of this on temperature monitoring, what you see are multiple technologies. And the one technology that has been properly tested is effective and is even cost effective. But what you need to do in a guideline, but also if you look at clinical care, is you need to be aware of the many untested technologies that have never proven any effectiveness. You need to be aware of the burden for patients of having to do something on a daily basis while not getting an outcome. You have to be aware of the non-adherence to activity reduction when they do find a hotspot. You have to be aware that participants may quit and the harms that it can do to patients in reducing their quality of life. The second technology that I'm focusing on is going to be a bit shorter because we have much less evidence, and that's pressure monitoring. Continuous pressure monitoring is thought to be a really good tool in ulcer prevention because pressure is causing the ulcer. And if you give a patient a warning the pressure is too high, then you may be able to prevent the ulcer. And again, you see that there are getting more and more technologies on the market. But again, we only have one system that has been clinically tested in an RCT. But with this system, even though it's been tested in an RCT, you need to be aware that this system does not measure at the level of the skin. So it's put inside the shoe, and then the insole is put over it, and then it measures below the insole. So the pressures that you measure with that system are not the pressures at the level of the skin, while the pressures at the level of the skin are the pressures that causing skin breakdown. So we're not really certain what this system is actually measuring. And the second thing is this system warns you when pressure exceeds a threshold, but that threshold has never been validated in people with diabetes to be a threshold that causes food ulceration. So yes, it gives you a warning, but we don't know when the warning is given, and we also do not know why the warning is given, because there is no evidence that the warning system, that the warnings are given at the level of pressure that is causing a food ulcer. And the third problem that we that is around with this system is that those pressure measurements and the validity of the pressure measurements have never been made public. So there is no publication, there is no evidence at all that shows us that it measures accurately, reliably, and validly the pressures that it's measuring. So it's some sort of a black box, and we don't really know what it's doing, but it's been tested and the RCT is out there. So we definitely had a good look at the RCT because they showed some interesting results. And the title, as you can see here, claimed that it helps prevent food ulcer recurrence. But disappointingly, if you go into the paper, you can see that the system is actually not effective, because in the intervention group, 4 people presented with ulcer recurrence, whereas in the control group, 6 patients presented with ulcer recurrence. And that difference was clearly statistically not significantly. It's probably a difference likely by chance. The reasons these statements are made are because some of the patients in the control group presented with multiple ulcers, and ulcers were counted double. But the key message is that this system is not effective right now, the way it's been used in that specific study. And similar to temperature monitoring, what you see in this one is that more than 50% of the intervention group dropped out, stopped using the technology. And again, it's because the technology can be a burden to patients. So technology is really helpful, but it seems to be that at least 50% of patients will stop using it relatively soon. So it may not be helpful for all, or perhaps it's not helpful for most. So summarizing pressure monitoring, what we're seeing is that it's currently not effective. And please be aware when looking at these systems of exaggerated claims of effectiveness, the burden for patients, the non-adherence to the device use, participants quitting, and the harm that it may cause patients. So pretty similar to temperature monitoring. So to sum it all up, there are exciting new technologies that may help us in prevent food ulcers. And these new technologies still hold promise, but there is a big but, and you should be aware of all the buts that play around these technologies. These technologies are not the panacea. They're not going to solve all our problems that we see in food ulcer prevention. They may help in some patients, but we have to study them much more cautiously and much more rigorously to understand in which patients these technologies may be helpful. And with that, I'd like to end this talk. Thank you all for your attention, and give the microphone back to our president, Vijay.
Thank you, Jaap. I think prevention is very important for especially the developing world. And I think you have addressed all the preventive aspects. Because of the increasing cost, I think the developing world needs these guidelines. And you have really told us about the preventive guidelines. I'll request our European chair, Dr. Abbotto, to introduce the next speaker.
Okay, the next talk, I like to introduce Eric Seneil from Nancy, that spoke about a very topic problem, infection. Please, Professor Eric. Are not?
No, Eric is coming. I think he's unmuted.
Is not here?
Yeah, Eric is here. Yeah.
Okay.
Can you see?
Sorry.
Yeah,
Can you see my slide?
Yes,
It's okay.
It's
Okay.
perfect. Eric is
Thank you,
perfect.
Roberto. Okay, thank you. Thank you, Roberto. Thank you, everyone. So my talk is about the guidelines on infection. The group responsible for the 2019 guidelines included 12 persons, and we now
Please
have moved to,
put in full screen.
oh, okay, like this.
No, it's better the
Full screen, yeah.
full screen, please.
I am in full screen. You don't see it?
No.
Okay.
Yeah,
No, but
you can go on. You can go on.
if you cannot,
Okay, it's okay for you? You can
Yeah.
see it?
Yeah, go
okay,
on.
okay.
Okay.
Thank you.
So the new group is now a larger group, as you can see, because we have 15 persons now, and 3 persons from the last group had to leave because of retirement, essentially, for Ben Lipsky, the chair, and Shigeru Kono. So the main point is we now have 6 new members, and this is to me very important because the new members are able to discuss and debate about what we've written in 2019. This is the first point. The second point is, as you can see, we have now a referent on methodology we didn't have in 2019, Zaina El-Balawi. And this is very important, in addition to the fact that every members, and this is new compared to 2019, have been trained to use the GRADE program to look at the data and to go from evidence to the recommendations. And this is highlighted. We now have, and to me, this is probably the main event regarding the constitution of the group. We now have 3 members that who represent the Infectious Disease Society of America. So it means that for the first time, we will have guidelines provided by IWGDF and IDSA together, not close, but together. 3 members, Maji Al-Hassan, Gina Valizon, and Oran O. So 2 ID physicians and 1 radiologist. And in addition to these 3 members, and Zaina El-Balawi, we have now Ilke Oeske, an ID physician from Switzerland, and Zhang Rong, 2 from China, 2 infectious disease physicians. So we had 2 main objectives as for every group: to look at the new data since 2019, and to look at what we have written in 2019, because we have upgraded the methodology due to the presence, I repeat, the presence of a reference on methodology and the training of all the members of the group. You probably remember that the IDSA provided a guideline for the diagnosis and treatment of diabetic photosomolitis. It was published 10 years ago, and you can see that 5 of the expert panel at this time belonged to both IDSA expert panel and IWGDF, Ben Lipsky, Anthony Berendt, Edgar Peters, John Embill, and myself. And in the 2016 guidelines from IWGDF, you can see that almost about half of the participants belonging to the IDSA. So it's not surprising that the recommendations from the guidelines of IWGDF and IDSA at this time were very close. So it seems really logical to have guidelines provided by both IDSA and IWGDF at the same time. But again, it is the first time. So I think I might not be quite objective because I'm an ID physician, but probably IWGDF and IDSA are the guidelines which are the most used over the world. So I think it is a very good point to have this collaboration between IWGDF and IDSA. So during the period 2019 and 2023, new papers emerged.
Eric, we're
Sorry?
still seeing slide number 3, and I think you're at slide number 6 in your talk, but we're in the screen, we're still seeing slide number 3.
I don't know why, Yep. You cannot see the slides I can change because
No, we see the slides, but not the presentation.
I don't know why, Yep.
Yeah, now we see something changing. So maybe if you just stick in this screen and then click through it, because now
Okay.
we can see.
Okay.
Yeah.
Okay. So I do not put in a full screen. So as I said, during the period 2019 and 2023, we had to review for diagnosis 3,700 papers, of which 30 were including the systematic review, and for intervention 5,400 of papers, of which 35 were including the systematic review. As usual, we'll have 2 systematic reviews, one on diagnosis, one on intervention, published separately, in addition to the document on the guidelines. So compared to the last round, we could not have physical meetings because of the COVID-19 pandemic. So we replaced, if I can say that, the physical meetings. But during the last round, we only had 2 physical meetings. And you can see that we replaced these physical meetings by 10, 3 in 2021 and 7 in 2022. They were virtual meetings during which we discussed about the process and the data we could produce after reviewing all the papers. We used a list of relevant clinical questions which are very close to those we used in the last round, 4 for diagnosis and 4 for treatment. For diagnosis, the first one was about the accuracy of the IWGDF IDSA definition of infection and the classification of the infection severity. Does it carry prognostic utility for outcomes? The second one was about the best method to identify the causative pathogens in soft tissue and in bone infections. The other one was about the diagnosis of a bone infection. What was the accuracy of the available tests for diagnosing osteomyelitis? And the same for assessing the monitoring and determining the remission of osteomyelitis, which was new compared to 2019. Regarding treatment, we looked at if there was any particular, any new data on the effectiveness of any particular antibiotic regimen, especially the specific agents, the route of administration, and the duration, because we have new data regarding duration of treatment for both soft tissue infection and osteomyelitis. Point 7 was about the difference between the surgical and medical approach of diabetic foot osteomyelitis, and the last one was about the use and the potential benefit of using some specific adjunctive or topical treatments in addition to systemic antibiotic treatment for the management of soft tissue and bone infections. So very briefly, I will look at the evidence statements we had, not the recommendations, because recommendations are still under discussion. So the first one is about IDSA IWGDF definition of infection. And we have data showing that this definition correlates with the patient outcome, especially ulcer healing, and the risk of lower extremity amputation or the risk of death. We had a lot of discussions about the distinction between class 3 and class 4 because of a paper published by Larry Ravray's team in 2020 in Clinical Infectious Disease Journal. Because in this paper, they didn't find any significant difference between patients with class 3 and class 4. But given the fact that it's a retrospective, unique study on this point, we think we should not modify the current classification. And the other point was about the use of the systemic inflammatory response syndrome, the SIRS, or the sepsis, which is the definition of sepsis provided in 2016 by the International Group on Sepsis. But sepsis is more a tool to use when you want to screen patients who are at higher risk of bad outcome if they have an infection. And we didn't find convincing data to modify the use of SIRS in our definition and screening of patients with moderate or severe infection. So this is the data we have on this first point. The second point is about microbiological diagnosis of infection. And we have some data with consistent results showing that if you compare culture and non-culture techniques, obviously you will identify more microorganisms using non-culture techniques, just because, as you know, these cultures are not modified by the previous antibiotic treatment. They are very powerful, efficient to identify any microorganism, especially for the next generation sequencing techniques, the NGS. But the problem is, the goal is not to obtain a lot of microorganisms. The goal is to obtain the bacteria or the microorganisms responsible for the infection. And this technique cannot say whether the microorganisms that have been identified are living or are dead. The second point is we don't know whether they are pathogenic or not. And the third point is you don't have very precise data on the antibiotic susceptibility profile of the agents. In addition, these techniques, non-culture techniques, biomolecular, PCR, and so on, are expensive. They are not available everywhere. So when you combine all these data, we are not convinced by the utility of these techniques, even if they are really effective in identifying microorganisms, but we think they are not very useful for the management of patients. Having said that, these techniques are absolutely indispensable to understand how a chronic wound works regarding microbes. But it is important to differentiate the research and the pathophysiology of these chronic wounds and the routine practice. So this is the reason why we probably will not modify the recommendations we had in 2019. Regarding the inflammatory biomarkers, erythrocyte sedimentation rate, C-reactive protein, procalcitonin, we have new data showing that they could be interesting for the distinction between diabetic foot ulceritis and non-diabetic foot ulceritis, I mean bone or non-bone infection. Of course, it is still important to consider the diagnosis of osteomyelitis using clinical signs, the type of the wound, the extension, the duration of the wound, and so on, the presence of a proctobone test, the abnormalities of plain X-rays, but these markers could be useful in case of persisting doubt after these very basic elements. Regarding imaging, the data still confirm that MRI is probably the best imaging technique if you have a persisting doubt regarding the existence of a bone infection in this setting. Third point is about bone biopsy. We have a lot of, not a lot of, but some studies on bone biopsy, and the evidence statements regarding the results we have is that they confirm the low correlation between bone and non-bone culture results. So if you want to have a reliable documentation for bone infection, it is better to have bone culture. The problem is, as you know, it's not available everywhere, in every situation, in every center. And we have, at the moment, two clinical studies, one retrospective and one prospective study showing that bedside percutaneous bone biopsies can be made. It is feasible, it is safe, it is an important point, it is safe. And if you consider the results of these two studies, we can suggest that these new data may ease obtaining bone culture results if you cannot obtain biopsy by surgery or by radiology because you don't have a motivated surgeon or radiologist to perform these bone biopsies. So probably this is an important new data. Antibiotic treatment prior to biopsy is likely to augment the risk of a negative culture. This is a very debated question, but we have new data in favor of this statement, which seems to be logical because it is confirmed in other settings. And the last one is about the intervention when you perform a bone biopsy, because in a study, they compared a bone biopsy through the ulcer with the risk of contaminating the sample by the colonizing flora compared to a biopsy performed via a healthy skin, so a distance from the ulcer, and obviously it seems better to use a bone biopsy performed through a healthy skin. So it's a new data again. Regarding treatment, we didn't find in the new papers or during the period 2019 and 2023, we didn't find any new papers that are likely to modify the conclusions we had in the last round of the guidelines. Regarding surgery, we have data showing that in case of acute severe DFI, early surgical debridement is likely to reduce the likelihood of a major lower extremity amputation. These are now new data from at least 3 papers. And we confirmed that the treatment with primarily surgical or non-surgical, it means only antibiotics approach in selected patients. And these patients have 4-foot diabetic foot osteomyelitis, no peripheral artery disease, no exposed bone, no abscesses, so a very strict selection of patients. And the data show that medical or surgical treatment provide the same results regarding outcome of the patients. Second point on the treatment, some studies, especially from Switzerland, the group of ILK have worked on the duration of treatment. We have data showing that in patients with moderate to severe soft tissue infections, a post-treatment, which is a post-debridement after surgery, antibiotic could be 10 days, and they compared 10 days to 20 days and didn't find any significant difference. So we have these data to precise the optimal duration or the minimal duration of treatment after surgery for severe, moderate to severe DFI, soft tissue DFIs. Regarding bone biopsy, we have a new study showing that we can use only 3 weeks of antibiotic treatment, systemic antibiotic treatment after amputation for a DFO if the bone margin culture is positive, and if the treatment is, if the patient is treated without any bone resection, the maximum treatment, according to only one study, is still 6 weeks. And the last one about treatment is about the adjunctive treatment. again, we didn't find any new data that are likely to modify what we recommended in 2019 regarding the use of a topical treatment. I mean topical antibiotic, because we restricted our systematic review on antibiotic and topical antibiotic. I mean cream, sponge, a gel, even loaded antibiotic cement for the treatment of diabetic osteomyelitis, but we didn't find any study that that show a benefit, a significant clinical benefit using these adjuvant treatments. And we are still waiting for the results of the VA Intrepid study, which is a randomized control study on progress in the US at the moment. They are comparing rifampin and no rifampin for the treatment of staphylococcal diabetic osteomyelitis. But at the moment, we don't have a result showing that we should or should not use rifampin. So at this moment, we don't have a clear conclusion regarding the use of rifampin in these patients. So this is a very brief status of the evidence statements we obtained after reviewing all the papers. And we are, as I said, still working on the recommendations on the diabetic foot infection diagnosis and treatment. So thank you very much for your attention, and hope to see you in The Hague in May 23. Thank you.
Thank you, Eric. Abbas, there's one more talk by Yap on translations, after which you can take the questions. The questions are there in the chat box.
Okay. Thank you again, Eric. It was very nice. The last talk is by Dr. Jaap Wijn again, and he's already been introduced, and he's a well-known personality. Everybody knows him. And his last topic is translation and implementations of guidelines. Welcome, Jaap. Floor is yours.
Thank you so much. I am opening my talk, which should be here now. So you've heard many talks about guidelines and giving you some expectations about what's coming up. But in this last talk, we want to focus on, well, guidelines and then what happens then? So what do we do as IWGDF, and what room is there also for many people in this audience and people all over the world to contribute? So guidelines and then. Because what you're seeing here is the guidelines being handed over by Professor Nicolas Schaper as chair of the IWGDF editorial board in The Hague to Professor José Luis Martinez on behalf of DFOD International and Professor Bolton from the International Diabetes Federation. And so clearly this is a moment where the IWGDF hands over the guidelines to organizations who are in the field and who are doing a lot of the work in the field in implementing the guidelines and getting the guidelines further. Because translation and implementation is not something that we as IWGDF can do on our own. This really is a collaborative effort by all the organizations and all the people all over the world. And DFOD International clearly is playing a major role here, looking only at the events, for example, they're organizing this week. So translation and implementation, what is there to tell you about? Well, guideline translation is something, because it's so closely to the IWGDF, that we as IWGDF coordinate and facilitate. But guideline translation is obviously done locally. I speak Dutch, which is the only other language that I speak besides English, and I can't translate the guidelines in any other language. And the same holds for various other persons. So we really need the local teams to do this. And what we prefer is that this is done by a national organization and a multidisciplinary team, because even in translating, even taking a literal text in English and translating it to the language that you speak, there is always subtleties involved. And because care is so multidisciplinary in the field of diabetic foot disease, we think it's important that this translation is done with a multidisciplinary team to make sure that the subtleties of your local language are accurately reflected in the translation. And doing this on behalf of or together with the national organization obviously strengthens the guidelines, the translated guidelines in your specific country. Because the IWGDF writes the guidelines in English, what we also require for any translation is that there's a copyright transfer statement. Yes, our guidelines are freely available, but the copyright is still there. But we want the guidelines to be translated. And so this is a mere formality, but it's one that we want to get right in order to prevent us from having problems later on. And what the IWGDF will do is check the guidelines. And even though I can't read languages, Google Translate is a great help, but it's also a good way to make sure that the IWGDF stays involved in the process of translating and seeing the final document that gets there. And that is the literal part of translation. But what you can also do if you want to go for a translation is that you can make a local adaptation. And I saw some questions already being popped up about the various different parts of the world. Obviously, there are many different settings in the world, and the IWGDF tries to write guidelines that are globally. And in a global guideline, you can never cover all the potential local differences. But if you translate a guideline into one specific language, you can add parts that are specific for your local circumstances. So you can make, and you have the room to add local adaptations. But what we always stress in those cases is that those local adaptations are clearly different from the IWGDF guidelines. The guidelines are globally, the local adaptations are made by the local team. So if it's clear what the difference in local adaptations are, you have the room to make them and to add them. And there's even another option to go, which is to do a full adaptation. And a full adaptation is called a process that's called adaptee, and even all of that does mean something, but it's all created by the people who also made the GREAT methodology, the methodology that we follow. And we're pretty proud that there are already 3 countries that have followed a full adaptation round. And the reason that these 3 countries, so in an adaptation round, the first thing you do is you look at all the different guidelines that are available, and then you pick the one that scores highest in quality and lowest in risk of bias. And those 3 countries all chose the IWGDF guidelines as being the most extensive and the most high quality guidelines available. They followed an extensive process. You can read about it in their documents. And now in Australia, in the Czech Republic, and in Tunisia, there is a fully adapted IWGDF guideline in the local language, being English, but then for the Australian situation, being Czech, or being French for the Tunisian situation. You can find these adapted guidelines on our websites. And here you can see the booklets that they made by it. So clearly this is not a translation, but it's a more rigorous and much more extensive process, but still keeps the IWGDF guidelines at the core of these documents. A translation is a slightly easier process because what you do is you translate the current global guidelines into the language. And the 2019 guidelines have, in addition to these 3 adaptations, also be translated in already 12 languages. 11 are available, and the Indonesian translation will be made available in November. So they'll be online very soon. And if you look at the languages that it's now available in, being Spanish, Brazilian Portuguese, Portuguese, Chinese, French, and German, for example, what we cover with that is the local languages of more than 2 billion people globally. So the guidelines are available to all these people. And this is only possible thanks to all the efforts of all the local people who work in these translations. And here you can see what these documents look like, for example. And so you can follow the IWGDF layout, but you can also make it a slightly more version of your own setting. And we're really proud that there are so many people all over the world willing to spend the time and effort in translating the guidelines into the local language and make them much more available to many more clinicians, because the more clinicians we reach with the guidelines, the better the care will become all over the world. And so will we be doing translations of the 2023 update because the guidelines will change and have to change because the world is changing? Yes, of course we will be doing so. And if you're interested, we will be reaching out to those who translated in the past. But if you're interested after hearing this, please feel free to contact us in advance and we can start discussing the process and see what's available. But obviously, a translation is only the first step. After a translation, you need to implement the guidelines into your care system. And is implementation any effective? Well, we're very glad that we have two studies, one from the chair of today, Roberto Anicini, and then one from Sweden, who not only implemented the guidelines, but also analyzed the effect that implementing the IWGDF guidelines had in their local settings. And the results of those two studies have been summarized by Matilde Montero Soares, who you also heard earlier today, and presented at a conference. And as you can see here, both in Italy and in Sweden, implementing the guidelines resulted in a clear reduction in major amputations. So yes, implementation, as far as we know, in those two countries works. Obviously, in many more countries, guidelines have been implemented, but it's really hard to implement and also collect the proper evidence to show that it works. But we're really happy that these two studies do show so. And at that same conference, and then later on in a paper, Matilde Montero Soares also looked at all the studies who looked at implementing structured foot care. And that could be based on the IWGDF guidelines or similar guidelines or a group of guidelines. And if you look at all the studies that implemented guidelines and implemented structured foot care as recommended by the IWGDF, you again see a meta-analysis as presented earlier, and you again want to focus on the black diamonds, and you again see that's on the left side of the bar, which means that it is effective. It clearly prevents lower extremity amputations. So yes, implementation works. But with implementation always going on and so hard to collect actual data, what we did in Australia in a study that was supervised by Peter Lazzarini and where Yuqi Sheng was our PhD student doing all the work, we looked at if we model the outcomes, what will happen? Because modeling is a useful way, if you don't have the data and if you don't know it, you can, well, make estimates about what might happen if you implement evidence-based care as recommended in the guideline. And what we did in this specific study is we looked on the total left, what you're seeing here is the current situation in 5,000 patients that were collected in Australia, where around 30% of them were receiving guideline-based care, which means that in all the data that we have available, we can see that they're receiving the care as recommended in the guideline, and 70% were receiving suboptimal care. That's not necessarily bad care, but it's not as good as complete as recommended in the guideline. And what we then modeled is, well, obviously you want to go to scenario 7, where 100% of your patients get guideline-based care, but that's not very realistic. So what we modeled is step changes. What happens if you improve care for 10% or for 20% or for 30%? So what if you improve the number of the percentage of participants that get guideline-based care by only small steps? And then we looked at the effectiveness, but also the cost related to it, because guideline-based care can be more expensive in the beginning in order to gain something later on. And what we're showing you here, and I won't go into detail in explaining you what you're seeing here, but what you can take home from this is that every improvement in guideline-based care, even improving 10% in your population, is already cost-effective. So what you see in here, cost-effective in 70% of the cases, so that means the vast majority, and dominant in 60%. So that's not only cost, so it's improving the quality of life by more than you expect. And if you achieve 100% guideline-based care, you are cost-effective in almost 90% of the potential situations. So what you see in here, and you see that the uncertainty grows in the second picture, but what you really have to take home from this picture and from that specific study is that even a small change and a small improvement in implementing guidelines is already saving you money and improving the care, improving the outcomes for all of your patients. And the more you can implement, the more you save and the more you improve. So implementation in clinical practice, what we know is that it improves outcomes. It's an ongoing process. It will never stop because the world changes, your patient changes, and the evidence changes. And it's a collaborative approach. It's something where we need everybody to work together as hard and as good as we can. And with that, I'd like to conclude this presentation and give the floor back to Dr. Abbas. Thank you so much for your attention.
Thank you, Jeb. So such a nice summary. Everything was covered. Thank you very much. We have few questions in a chat box, so we can start asking. Professor Nicholas, will international working group guidelines be relevant to the developing world?
Well, I think some of, at least part of this question, in my opinion, is answered by Jaap.
Yes.
What we try to develop with our guidelines is a do-it-yourself guideline toolkit. We're not giving the answer how all patients should be always treated in all situations. Impossible. In Brazil, in the jungle, it's quite different from Alaska, in the snow, from India, where people go to the temple barefoot, from my country. So you have to translate it. But the principles behind the guideline, for instance, in a plantar foot ulcer, you should always offload it. That is the same wherever you are. But of course, we do realize that if you go to the temple, you have to think about how to solve this, if it's possible to solve it, for instance. So yes, I do think that the guidelines are very relevant for developing countries. But on the other hand, we have to realize that just simple translation for these countries in many instances is probably not sufficient. And they should be either slightly changed or completely adapted, like Jaap said.
Thank you, Professor Nicholas. And I think I will also add that I think you managed to cover each and every section in guidelines. There were people from developing world, including myself from Africa, and there were reviewers even from developing world. So we had a briefing from there, and the rest what you answered was perfectly agreeable. Yes. Dr. Martila.
Sorry, if I may add, I realized, sorry, I'm impolite, I'm sorry, Abbas, but you know.
Yes,
I realized also something which I learned from you, from people from the developing world, is, and that's a discussion we frequently had also in earlier DFOOD meetings, why you set the standard so high, people asked us. Because we don't have this, we don't have that. But that's the whole reason we set the standard so high. I turned the question around. If we say that somebody with peripheral artery disease and severe ischemia should have revascularization, of course we realize that in many areas of the world that is not possible. But there is simply no alternative for that. And by stating that that should be done, the revascularization, we offer the people in the developing countries, in particular also in the middle income countries, tools where they can go to their healthcare bureaucrats and say, this is what the global guidelines say, and this is what we should do. Now the healthcare system should adapt in order to make this possible. Sorry for the interruption.
No, that was a very valid point. I'm at the moment in Kenya, Nairobi, doing a meeting in diabetic foot, and Minister of Health this morning approved diabetic foot as one of the priority. So it took us ages, 30 years, and people were very happy that it has been accepted now. And the podiatrist was not even on the list of registration, and they have now accepted podiatrist as a podiatrist, not a pediatrician. So, so this is well done. It's what you said. That's boss. Okay, Dr. Maltida, your question, there is any difference between classifications like Wi-Fi, SINBAD, etc.?
Yeah, we completely believe that the classifications are really different. And this is one of the reasons why we don't believe that one classification will fit all scenarios. Because if for a first assessment and to try at least to stratify patients, we need a simple tool that is easy to collect, not dependent on experience, and that you can do it in a short amount of time, that will not be reasonable to use in tertiary care, where you need to understand exactly who will have more risks, who will require specific management. So you will need more detail, but it's not expected for you to ask in all the settings the same questions and the same level of detail. It's not feasible. it's not cost effective. And so we really need to look to the differences between them, but again, selecting those that at least we have any evidence that they are at least useful in any of them. But then to look at those differences and select the best ones for those specific scenarios.
Yeah, great.
So
Thank you
they
very
are,
much.
and we agree they are different and they are supposed to be different.
Yes. Friend, there's a question for you. Will the new guideline help us to recommend wound dressing and etc.?
Absolutely. Good question. If they don't, then there's probably no purpose in having a guideline. So yes, absolutely. They are going to, the wound healing guidelines cover dressings, applications, pastes, topical oxygen, hyperbaric oxygen, skin substitutes, fish skins, placental membranes, other gases. They cover the whole range. But yes, in particular, we have a section on, simple wound dressings and topical applications. Now, where there is good evidence and where there has been, in particular, cost effectiveness data in many healthcare settings, such as, for example, sucrose octasulfate, and we haven't formulated our guidelines yet, but as that one I know is not going to change. Nobody has said this is not effective. It's not cost effective. In fact, the cost effectiveness data is growing around the world, and where you know that it is feasible and acceptable to patients, and yes, we can make a recommendation to use that topical application or dressing. There are many others. I just use that as an example of one that we've used that was recommended in our previous guidelines, and we don't expect that to change during our voting procedures. But we will always recommend them in addition to best usual care, where best usual care has not actually healed the wound. So we do need to understand that the basics are often enough, and then anything on top of that is additional. Where there is no evidence, published evidence of randomized controlled trials, then we may not be able to make a recommendation at all. So there may be lots of applications that people are using that we are unable to make a recommendation on because nobody has published any data. But absolutely, the guidelines will recommend classes of wound dressings or agents that could be used in addition to best practice care, where best practice care has not helped that also. And we will also include some discussion about whether that would be feasible and acceptable in low middle income countries as well. That's obviously very important.
Yes, ma'am. Thank you very much. I think you covered everything. I have nothing to add there. Thank you. Jeff, there is a question for you. Is International Working Group on Diabetic Foot 2023 throw some lights on preventive aspect depending on the various social, culture, habits of the people in different parts of the world?
Yeah, I think I need to be upfront with a disappointing answer is no. Not that specifically and not that particular. And let me explain why. We're following the GREAT process, which means that we are really bound by the published evidence and the aspects that have been studied with enough quality for us to make statements about it. And this specific aspect has never been studied in an intervention. There's never been an intervention that has that looks at specific habits and specific differences in sociocultural habits and the potential of intervening in them and changing them and differences in outcomes that you get. And the second thing is, it would be such an enormous topic to cover all the potential differences here that's just not feasible for a global guideline. But there is a but. What we do describe in the guidelines, especially in the education section, but also in the self-care section, is that we do describe the importance of making sure that what you recommend and what you discuss with your patient matches their specific situation. And we give some examples of how to take that into account and how to discuss with your patients their local habits and their personal preferences, because we know that they are important. But really looking into that much detail, that is something that is more relevant for local adaptations and local translations, because it changes. But even if I look at my own country within the Netherlands, it changes depending on the city you live in or the background that you're from. So even for our country and our guideline, we can't make specific recommendations based on that. This is really where the art of being a carer and being a clinician comes into play, where you discuss with your patient what do you do, and how can I then make sure that the recommendations, the more general recommendations, match with what you will be doing in your specific situations. But we do take this at our heart, and we'll have a look at the guideline to see where we can be maybe a bit more explicit and maybe a bit more clear in what are potential local or cultural habits that may interfere, or and look at potentially published evidence. But yeah, the thing with the guideline is we really have to stick to that process and to what is published. And if there is no scientific evidence, then we have to be very cautious in what we describe, because it suddenly becomes expert opinion. And if I say something, well, who knows, I am an expert, but my knowledge may be so limited, and I know so limited of other situations, that I try to be very cautious in what I specifically say about situations that I don't know too much about.
Yes, Jeb, thank you. That was a nice reply. And I would just say that you had already mentioned in your talk, and then it was also supported by Professor Nicholas, that the guidelines are the journal guidelines. Then when it goes to individual country, the 192 countries, you can't write everything in one guideline. There's going to be a very fat book. So everybody has to then individualize it, specifies it. Okay, I don't see any more questions.
I saw one more question coming up, and let me take it up, because it's about translation. So the comment I see in the chat is that it's very important to translate it into various languages, like Spanish, Portuguese, and Vietnamese. Well, as I showed you in my talk, so the 2019 guidelines have been translated into all the major languages and the languages spoken by many million people, but also smaller languages, because people in countries that are much smaller have approached us. And yes, for the 2023 update, we are again actively pursuing this, and we're also very open to anyone who's willing to do this to approach us. The process is written on our website, so please go there and reach out to us if you have an interest. And at the same time, yes, we will be doing this, because translating it in as many languages as possible is really important.
And if I may add, it is a quite unique situation, because we do it for free. Where can you just copy, about 30 documents, 150 pages all in all, if you want to copy them all, and get them for free? Because this work has been done, like I showed in my introduction, it costs thousands of hours of work. But we're all idealists, and we hope as much as possible that everybody will, that all healthcare workers in the world will be enabled to read our guidelines, adapted or not.
Professor
Yeah,
Schapper,
thank you very much.
Professor Schapper, there's heavy showers here, so I'm not able to switch on my camera. So I would like to thank AWGDF for this opportunity to work with DFOOT International, and I assure you DFOOT International will take up the translation implementation for which we were created. Thank you very much. I'm not able to switch on my camera because
thank you very much.
Thank you.
Well, again, on behalf of the whole team, thank you very much, Roberto, Abbas, and Vijay, for giving us this podium to tell people something about where we are at this stage and what we hope to aim and to reach with our guidelines. Thank you very much.
Yeah, I also thank you
Right.
all for a very nice, I mean, this was a really very nice brief before we go to the main thing. Before we end, there is another session, and I would ask all the participants to stay. There is a Urgo session. So if you can wait, it would be very nice. Thank you very much.
Tech team will
Thank
show
you very
you.
much.
The tech
Nice
team-
day.
Yeah.
We will see in Prague.
So
Okay.
good afternoon, ladies and gentlemen. Welcome to this sponsored symposium by Urgo. It's a pleasure for me chairing this symposium and to introduce our speaker for this afternoon. So in first place, we have Dr. Dietlein from Germany. And then we have Dr. Meloni from Italy, and finally, Dr. Ludemann from Germany as well. My name is José Luis Lázaro. I'm working in Complutense University in Madrid, Spain, and I'm working with diabetes food as a coordinator of the diabetes food unit over there. So the symposium is focusing obviously in diabetic foot patient, but according with the new theory or new idea that Urgo is spreading around the chronic wounds. Is concerning what kind of patient do we have, or better said, in what kind of patient this patient can have an ulcer that are at risk for delayed healing. And without any doubt, diabetes patient is some of them, and diabetes patient can develop diabetic foot ulcer. A diabetic foot ulcer is one of the etiology that can suffer for undelayed healing. So Urgo investigated for a long time ago about new solution and management about this patient, and we are going to share with you some of our investigation and research concerning the management of this kind of patient and how this approach can achieve a faster healing and reduce complication in this very complex disease. So I now will give the floor to our first speaker, Dr. Dietlein from Germany, for talking about ulcer with site of infection.
With this team, and as we all know, diabetic foot ulcers are at high risk of infection for many reasons. Environmental conditions are conducive to bacterial multiplication. We often saw wounds with plentiful supply of nutrients, and most of the patients has neuropathy and sometimes also poor blood supply, so that we must also improve the poor blood supply, and the wounds are often contaminated by either environmental organism from surroundings and or the patient's floor. And so there are many reasons, because the biofilm is a big problem because it inhibits the healing and can lead to local infection. So the therapy is multimodal. We need debridement, cleaning, topical treatment, and very often also systemic and antibiotic therapy. Here you have a typical example for a patient with diabetic foot syndrome. You all know the typical signs of the infection. For example, increased wound temperature, edema, increased levels of exudate, bad smell, pain, but we must realize many patients with neuropathy, they have no pain. That's very dangerous. And also extending redness. And there we consider using a special antimicrobial dressing, or very often also systemic antibiotics. So here I show you the 4 categories of the diabetic foot syndrome. in aspect of infection, category 1, no infection. We use also only standard treatment with local dressing. We need no systemic antimicrobial therapy. Then category 2 with mild infection, but the wound is not so big. Treatment here is debridement, cleansing, antimicrobial dressing, and also very often systemic antibiotics. Then category 3, moderate infection, no systemic manifestations, but the wound is bigger. We treatment again with debridement, cleaning, antimicrobial dressing, and systemic antibiotics. In category 4, the severe infection, associated manifestation with fever, increased heart rate. Here is the danger of sepsis, and here we also need systemic antibiotics. So the general principles of infected wound management: first, we must assess the wound, especially assess the severity of the local wound infection. For example, redness, heat, swelling, pain, stasis, increased exudate. And it's important, before we begin the therapy, to have a culture, to know what kind of microbes are in the wound. We need a wound swab, often a biopsy. And then third, timely surgical intervention, especially if there's a deep abscess, necrotic tissue, or bone infection. And appropriate systemic or local antimicrobial treatment, there we have in all countries, we also in Germany, we have national guidelines. What about the use of systemic antibiotics? In diabetic foot syndrome, we often use antibiotics in our center. First, when we have no result from the culture, we use a broad spectrum antibiotics, for example, penicillin with a broad spectrum. And then when we have the result of the swab, then we can treat sometimes with an antibiotic with a narrow spectrum. Systemic antibiotics are essential, especially if the patient has signs of sepsis. That's very dangerous because of the follow-up. And if the patient has sepsis, then we need intravenous antibiotics. And here we have also guidelines in our hospital for using special antibiotics. And we not use topical antibiotics in acute or chronic wounds because the results here are not good. We have not enough dates that a topical antibiotic is adequate treatment for the diabetic foot syndrome. What about antimicrobial dressings? All dressings are tested because of toxicity and safety. They are also tested in treatment with diabetic foot ulcer. I further on show results of studies. We use it for around about 2 weeks, sometimes for 3 or 4 weeks. And then we have we must have a look regularly on the wound, and when the infection is away, then we change the dressing and further on use, for example, instead of Urgoclean AG, then, for example, Urgostat with a better result of the wound healing. wound infection, especially when we treat patients with diabetic foot syndrome, creates a vicious cycle that causes tissue damage. We have much exudate that decreases the wound healing, the presence of slus that favors microbial proliferation. A great problem is the biofilm that limits the action of the antimicrobial dressing, and the microbes delay the wound healing. So there is no chance that the wound gets better if there are many microbes in the diabetic foot ulcer. So with OrgoClean AG, we have a good possibility to complete and continuous cleaning action by the polyabsorbent fibers that remove the sludge and exudate. And also with the silver ions, we have a good antimicrobial activity. OrgoClean AG is very well examined by many studies and controlled trials. Here you can see many different results. For example, cohort studies with many patients here, over 2,200 patients with chronic and unclassified wounds. Then non-comparative clinical trials here with venous ulcers, and also randomized control trials, for example, in comparison with Aquacel, also here examined in patients with venous leg ulcers. And by using OrgoClean AG, we have good results of lowering the antibiofilm activity here in comparison to OrgoClean. And you can see that in the results, more than 4-log reduction in the number of sessile cells after 14 hours of contact. So it's very good for lowering the numbers of microbes in the wounds. And here you can see a direct comparison to a silver competitor. Here again the comparison to Aquacel AG. And here were wounds also with microbes with many problems for us in the hospital. For example, multi-resistant Staphylococcus or Pseudomonas aeruginosa. And here you can see in comparison to the Aquacel AG that the results were better, that the biofilm activity when using OrgoClean AG was lower than when using Aquacel AG. So at the end, I have one interesting example from a patient. He has a hobby. He is a hunter, and about 3 years ago, after hunting, it was in March. It was very cold in Bavaria, and in the evening he goes in his hunting lodge, and it was very cold, and so he used a hot water bottle for his cold legs. And I often said to him, "Oh, don't use a hot water bottle, that's dangerous." And the next day in the morning, the left foot was scalded, and 2 days later he came to me with this wound. You see, that's March 2018, and yeah, and in the wound were many microbes also Pseudomonas aeruginosa. And so I began at once with debridement, with cleaning the wound, with using solutions like Octenisept, and also for local treatment, Ergoclean AG, and also systemic antibiotic therapy with a penicillin with a broad spectrum. I treat it in the hospital, and it lasts around 3 or 4 months, and then the wound was healing. And yeah, so it was a good result. And in the beginning, the patient was fearing that he can lose his foot. So I come to the end conclusion. So first, identification of local infection is often difficult and usually determined on clinical assessment. Second, guidelines. We have guidelines in Germany. I think in all other countries you have also guidelines are available to help with identification of local infection, created by a panel of experts and all available evidence. You can look at the guidelines here. Third, need of combined and antimicrobial action to fight local infection. I show you on the example debridement, cleansing, antibacterial dressings, here Ergoclean AG, and also systemic antibiotics. In most of the cases we use penicillin with a broad spectrum. And last but not least, refer your patients with diabetic foot syndromes, because we have high numbers of amputation, and we must lower that. We must need better results. And I think that this modern therapy with also modern good antibacterial local dressing help us to get better results. And so it's important that these patients visit a special center. Thank you very much.
First of all, let me say thank you to Urgo Medical for invitation. It's my pleasure to be part of this symposium. So, focusing on the talk, we know very well that the Explorer study showed the good results and the superiority of dressing with the sucrose octasulfate in comparison to neutral dressing, with a rate of injury of 48% in comparison against 30%, and a chance of injury of 71% in the case of ulcer with a less duration, with a duration less than 2 months, as reported by post-hoc analysis. But in the Explorer study, the ulcer located in the posterior part of the heel were excluded to avoid any kind of confusion to pressure ulcer. But we know that heel ulcer, especially neuroischemic heel ulcer, are very hard to be managed, and they reported usually worse outcome in comparison to ulcer located in the forefoot and in the midfoot in terms of healing, in terms of amputation, and in terms of healing duration, with the risk of amputation approximately between 15 and 20% at 1 year. But why? Because there are two specific reasons related to biological and anatomic characteristics of the heel. Because the heel is characterized by a fat pad without muscle, so it remains in a vascular structure. So we had basically an hypoperfusion, and this hypoperfusion is increased in the case of limb ischemia, specifically if we have a stenosis occlusion of posterior tibial artery. Second one, in the heel we have a very few rescue tissue in the case of lesion, so we have no chance to treat it by primary intention, as can happen in the case of foot or mid-foot lesion after demolitive or curative surgery or removal of bone. So probably we have to focus our attention to specific dressing to improve the chance of healing and to improve the healing time, because another way dressing may be a clear weapon as a part of integrated protocol of treatment. So according to this background, our thought was why not evaluate the effectiveness of sucrose octasulfate in neuroischemic ill ulcer with critical limb ischemia in patients with diabetes. So the study is a retrospective single-arm study with a prospective database. Patients included were consecutive patients we referred to our unit at University of Tor Vergata in Rome since January 2019 to January 2021. Patients included were patients with DFU belonging to grade 1C, 2C of Texas University classification, while excluded patients were patients with soft tissue infection, calcaneus osteomyelitis, poor neuropathy, with a life expectancy less than 6 months, and severe concomitant comorbidities such as cancer or autoimmune disease, or under immunosuppressant therapy that can reduce the chance of limb salvage. At the baseline, clinical assessment was performed, such as cardiovascular risk factor, such as ulcer assessment. All patients were managed by a preset limb salvage protocol according to the International Working Group on Diabetic Foot guidance. Specifically, revascularization of affected limbs were performed, and all patients received offloading both by walking, during the walking, and at the bed. After the demolitive surgery, after revascularization, demolitive surgery, or the first debridement after revascularization, all patients were treated by sucrose octasulfate as primary dressing. After discharge, patients were followed at home by nurses or trained caregivers or healthcare professionals which changed the medication usually every 3 days. And usually, any 2 or 4 weeks, the patient were evaluated at our foot unit. In the case of infection, the dressing was suspended and reapplied only after the infection resolution. The primary outcome was the rate of healing. The secondary outcomes were the healing time, the rate of wound regression, defined as more than 50% of original wound size, the rate of ulcer recurrence, major amputation, adverse events related to infection, and the follow-up was 24 weeks. Here are the baseline characteristics of patients enrolled in the study. 30 patients were included. The mean age was 6-7 years old, with a mean diabetes duration of 18 years. More than 15% of patients had ischemic heart disease, and 20% had end-stage renal disease under dialysis. The ulcer duration, the mean ulcer duration was 10, more or less 4 weeks. So we are treating, fortunately, young ulcer. And the mean TCPO2 after revascularization, all patients had successful revascularization of posterior tibial artery. The mean TCPO2 after revascularization were 42 millimeters of mercury. The values are good and better than the values before revascularization, but not optimal. They are non-normal values, so the patient had a residual subcritical ischemia of the heel. Finally, results. 73.3% of patients healed. The mean healing time was 84 days, more or less 32 days. Globally, almost all patients had a wound regression, 93.3%, and only one patient had a major amputation. No adverse events were related to the dressing application. So finally, the study documented a very good result in terms of healing and in terms of time of healing. The results are more or less comparable to the post-analysis EXPLORE study, with a chance of healing of a little bit more than 70%, with similar ulcer duration less than 2 months. The results are very good. Imagine the kind of patient we treated, because 20% were under dialysis and more than 50% had ischemic heart disease. So we can see after this data that the use of sucrose octasulfate can be used, can be applied with safety with successful in patient with heel ulcer and neuroischemic ulcer, and not only forefoot and midfoot ulcer. Of course, there are several limitations because it's a monocentric study. The sample is very small. The study is a no comparative study, so we don't have a dressing to compare to the dressing we used, of course, but we reported the safety and the good benefits of sucrose octasulfate in terms of healing and time of healing. Some very fast, quick clinical cases. This is a patient with 64 years old, female, with a long diabetes duration, no optimal diabetic control, with an ischemic heart disease. The wound duration was 6 weeks, grade 2C of Texas University classification. After the patient received a good revascularization with the opening the anterior tibial artery and reinforcing the flow in the posterior tibial artery with many collateral in the heel area. Finally, we performed a very extensive debridement, and we applied directly from first intention the sucrose octasulfate dressing in the first week, in addition to negative pressure wound therapy. And finally, we continue the use of Urgostart after discharge. Patient had the complete healing after 22 weeks of treatment. Another patient with 77 years old with a very deep linear lesion in the heel. Also, the patient with an ischemic heart disease. The wound duration was 4 weeks, grade 2C of Texas University classification. Also, in this case, revascularization, extensive debridement, application of sucrose octasulfate with a time of almost healing in 21 weeks. Finally, another patient, a young patient, 43 years, female with type 1 of diabetes under end-stage renal disease, with a wound duration of 8 weeks, belonging to grade 1C of Texas University. Revascularization, debridement, very sharp, very soft, sharp debridement, and application of sucrose octasulfate, and healing after 8 weeks of treatment.
Okay. The second part of this Urgo presentation will continue tomorrow in a global meeting. Because of constraint of the time, and we have already crossed almost 2.5 hours. So in the end, I would like to thank all the speakers of International Working Group who gave us a nice overview of the consensus. I would also like to thank the speakers of Urgo Medical, and as I said, is going to continue tomorrow. And thanks to Emily being very cooperative. I would also like to thank the board members and all the chairs of the regions. Thank you very much for supporting and disseminating this message all over the world. And special thanks to the core team and the IT service. It's our president's office, especially Selva, Kumar, and Nalini. Lastly, the big thanks to all of you, because without you delegates, this webinar was not possible. So a very big thankful to you. See you tomorrow for the global meeting. Thank you very much.
European Regional Chair, Roberto Ancini.
Roberto, if you want to say last word, Roberto. He had another meeting, so we can say thanks on his behalf for all the European region. Thank you very much.